Welcome everyone to YouTube channel of Hirad EP. We talk about interesting stuff in electrophysiology, cardiac electrophysiology. And this time today, we're going to talk about the atrial fibrillation guidelines. And in particular, we're going to talk about electrical cardioversion. And we'll talk about importance of anticoagulation prior to um, cardioversions and important things that we need to look into during and after the cardioversion. So let's take a look at what is the guidelines telling us. So first of all, we wanted to restore sinus rhythm for many reasons, right? One is for hemodynamically unstable patient, we need to terminate the atrial fibrillation if it's causing hemodynamic instability. The second thing is if you have a symptomatic patient because of atrial fibrillation, you want to terminate that. And this most effective way is electrocardioversion. Although electrocardioversion is very effective, but it needs sedation. It is more effective more on pharmacological interventions, but the patient needs to be sedated to doesn't feel the shock and also to doesn't remember that. Now, acute trial is the cornerstone of the information that we have in regards to anticoagulation prior to it and anticoagulation after to it. We have two category of patients. Patients that have atrial fibrillation duration more than 48 hours. If your atrial fibrillation is more than 48 hours, you need to have 3 weeks of uninterrupted therapeutic anticoagulation or imaging evaluation like transesophageal echo, which is a gold standard, or CAT scan of left atrial appendage to make sure you don't have left atrial appendage clot. Now, if you have atrial fibrillation for 48 hours, you got 3 weeks of anticoagulation, you're good to go, you can have a cardioversion. Now, after the cardioversion, the guidelines recommended 4 weeks of anticoagulation. So after the anticoagulation is verified and you got shocked out of the atrial fibrillation, you need to be on 4 weeks uninterrupted again of anticoagulation to prevent risk of stroke. Now, if you have left atrial appendage clot, so we get a CAT scan, we get a TEE, and we find that you have left atrial appendage thrombus. In that case, it's contraindicated to have a cardioversion. So then you wait 3 to 6 weeks, and then you check again. Usually, about 60 to 70% of the patient that had a left atrial appendage clot, they might have a resolution of that with appropriate anticoagulation after 3 to 12 weeks. So you wait 3 to 6 weeks, and after 3 to 6 weeks of waiting period, you do another imaging. And if the imaging shows that you have resolution of the clot, then you can proceed with cardioversion. Now, this was a more than 48 hours. What happens to the people that have an AFib duration less than 48 hours? It's a little bit challenging with the less evidence and also less clarity about what to do. So in these category of patients with the AFib less than 48 hours, we then look at see if there's a setting is after the cardiac surgery, right after cardiac surgery, or not. If it's right after the cardiac surgery within the 48 hours, and then of course during cardiac surgery you didn't notice any kind of left atrial appendage clot, left atrial clot, then you can go ahead and shock the patient, no matter what is the CHA2DS2-VASc score. But if the CHA2DS2-VASc score is significant, means in 2 and more, and then you have an AFib duration less than 48 hours and more than 12 hours, and you again CHA2DS2-VASc is significant, and then you need to again check and make sure there's no left atrial appendage clot. So you can do it with the TE or you can do it with the CAT scan. So less than 48 hours, if you have a surgery, cardiac surgery, and if there was no clot during surgery, you can go ahead and shock no matter what is your CHA2DS2-VASc. But if it's not in the setting of post-cardiac surgery and your duration, we know the duration is less than 40 hours, then you have two categories of patient. One is the high-risk people, CHA2DS2-VASc 2 and above, and another one is CHA2DS2-VASc 0 and 1. In folks that have CHA2DS2-VASc 0 to 1, and in particular is less than 12 hours, there might be a room for cardioversion of the patient without having anticoagulate before or need for imaging. So less than 12 hours with a CHA2DS2-VASc of 0 to 1, based on the guidelines, there is room for not getting imaging before the cardioversion or not being anticoagulated before cardioversion. Now, what happens with the patients that have a left atrial appendage thrombus? So patients that have a left atrial appendage thrombus, as I said, you check again with the TE and CAT scan in 3 to 12 weeks, and then you go from there. And if the clot is there still, there are a few ways to deal with that is out of scope of this presentation. Now, we're getting more and more patients that are having left atrial appendage closure devices, from Watchman devices, which was the first one, and also later on we have Amulet from Abbott company. So in these patients, two important things is important. Number one is these patients can get a device-related thrombosis. Up to 2.7 to 3% of the patient might get device-related thrombosis. So if it's not clear and is not checked, the left atrial appendage occluder device, it is recommended to do imaging, some sort of imaging to exclude device-related thrombosis, and also make sure there's no prevalvular leak and shows that the appendage closure is good to go, as well as there's no clot outside of that. So on one frequency, what is the distance between the last one and the last TE, for example? We don't have a clear answer from the guidelines. I usually go with the 6 months to 1 year. So as we see in the algorithm, they're recommended if you have AFib in post-cardiac surgery setting, and if it's less than 48 hours, you can go ahead and do a cardioversion. If it's more than 48 hours, then you need to do the usual imaging to look for intracardiac thrombus, and if there's a thrombus, you should not go ahead. You need to anticoagulate the patient. Now, in the patients that are not post-cardiac surgery, then you look at presence of the left atrial appendage occluder. If the occluder is present, then and also you're sure that the patient doesn't have a leak and doesn't have thrombosis, you can go ahead and anticoagulate. And I usually continue a few weeks of blood thinner after that. And if there's no anticoagulation, there's no left atrial appendage, and there's no anticoagulation before, then you need to have 3 weeks of anticoagulation. In one small category that we talk about it, with the CHAS-VAX of 0 to 1 and the duration less than 12 hours, you have a room to go ahead and cardiovert the patient without proof of anticoagulation. Now let's talk about how we're going to do the cardioversion and what are the important things to remember on how to do it. So first of all, 3 important things to remember: that if the patient is hemodynamically unstable and you think it's because of atrial fibrillation, you should not waste any time and then cardiovert the patient. The second important thing is anytime that you do that, you need to remember that your QRS is synced, and so you're not inducing VF while trying to get rid of atrial fibrillation. And if your cardioversion is not successful, you can try some pharmacological interventions and rhythm therapy that will improve the success of your cardioversion. So usually for AFib patients, we do a biphasic energy at least 200 joules, and that shows that will be beneficial and bring the success rate significantly higher. Another interesting thing is that if you do optimize your electrovector, there is some data about anterior posterior position compared to anterolateral patch position, which showed the anterior posterior might be better. So we in our institution, we tend to use anterior posterior, and we use a higher energy if the patient had a history of unsuccessful or the longer duration of atrial fibrillation. Also, of course, pre-treatment with antiarrhythmics, things like ibutylide, amiodarone, dofetilide, all of these medications improve the success rate of your cardioversion. And of course, we sometimes use a double defibrillator, and there are papers recently, randomized papers, about the utility of double defibrillators. We also did a study on the predictors of impedance, transthoracic impedance patient that getting electrocardioversion that you can follow here in the PubMed, and have a lot of interesting things that we found out in our study. So in patients with obesity and atrial fibrillation, use of manual pressure augmentation or further escalation of electrical energy may be beneficial to improve the success of the cardioversion. So sometimes we use manual pressure. The data is not solid about manual pressure. There are some recent data that shows it might not be as beneficial as it thought before. But still we use it because it has a low risk and it can be helpful. Thank you again, and stay tuned for our next week review of literature as well as interesting things about that we see in our guidelines. Thank you very much.